Good morning, everyone. I am Prashant Agrawal, and on the behalf of Adley Oncology, I would like to welcome all eminent speakers, panelists, and Dr. Satish. I would like to welcome uh, our chief guest, Dr. Prashant Bhatt, and I would like to welcome the eminent speaker, Dr. Aisha. Welcome, Dr. Panelists and the participants. Today, I would like to just give the brief about the Adley. That Adley is truly backward integrated company that develops API, manufacture formulation, and does the marketing and distribution of critical oncology products. Sir, today I would like to take the opportunity to tell you that Adley is standing besides you in your endeavor of being healthier tomorrow by providing quality and affordable medicine to all Indian patients, by providing patient assistance program, by taking the part to disseminate knowledge among SCPs through webinars, CMEs, and the awareness programs. Once again, I would like to thank all the medical fraternity to trusting on us. Because of the trust, we are becoming the fastest growing oncology company in India. Because of the trust, we have a presence in major oncology, major corporate and the private hospitals in India. Because of your trust, we are expanding globally. So, and lastly, because of your trust only, we are increasing our presence in hematology on hemato-oncology segments. We are the manufacturer and the marketer of the such beautiful products like carfilzomib, Bidan, dasatinib, plerixafor, azacitidine oral, azacitidine injection, peg-alasparginase. So we are the manufacturer and the marketer of these products. So thank you very much for trusting us, for encouraging us. And without any further delay, I would like to invite Dr. Satish Kumar for proceedings ahead. Thank you, sir.
Thank you, Mr. Prashant Agarwal. Good morning, one and all. Today, our guest speaker is Dr. Ayesha Sunawala. She will speak to us about modern antibacterial drugs in neutropenic subjects. The webinar is brought to you by Mumbai Hematology Group. It is supported by Adley Oncology and managed by Perfect Square as usual. I would like to thank Mr. Ashutosh Shukla and team Adley Oncology, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of the Mumbai Hematology Group, our chief guest, Dr. Prashanta Bhatt from Mangaluru, our guest speaker, Dr. Ayesha Sunawala from Mumbai, all our discussants who are themselves eminent hematologists or medical oncologists from various parts of India, and thanks to all the participants for sparing your Sunday morning or afternoon or evening from rest of the world. We have two interesting webinars lined up next weekend. The coming Saturday, that is 25th February, 7 p.m., we have Dr. Cindy Newnert from Columbia University Medical Center, New York, speaking on childhood thrombosis. And the next day, that is a Sunday at 11:30 a.m., we have our own Dr. Manju Sengar from Tata Memorial Hospital, Mumbai, who will be lecturing on peripheral T-cell lymphoma, diagnosis and management. Our discussants today are 10 personalities, and they have been put up alphabetically here. Briefly, to introduce them, we have Dr. Akansha Garg from All India Institute of Medical Sciences, Jodhpur, Dr. Archit Pandira Pandey from PGI of Child Health, Noida, Uttar Pradesh, Dr. Ashwini Narayankar from Tata Medical Center, Kolkata, Dr. Ganesh Jaishetwar from Yashoda Hospital, Hyderabad, Dr. Gopinathan M from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, Dr. Radhika KK from Nizam's Institute of Medical Sciences, Hyderabad, Dr. Mithun Abraham Prakash from CMC, Vellore, Dr. Nihar Desai from SGPGIMS, Lucknow, and Dr. Vishal Toka from MNJIO and RCC, Hyderabad. Now to introduce our special guest, it is my pleasure and privilege to introduce Dr. Prashant Bhatt from Mangalore. Dr. Prashant Bhatt is a hematologist at KMC Hospital, Mangaluru. He has finished his UG studies from JSSMC Mysore in 2003. In 2009, he did DNB in medicine from Narayana Hrudayalaya. And in 2012, he did fellowship in hematology from Mazumdar Shah Cancer Center, Narayana Health City, Bengaluru. He was instrumental in starting the first ever dedicated hematology center in Mangaluru, Karnataka in 2012 at KMC Hospital. Since then, he has been the head department of adult hematology at KMC Hospital, Mangaluru. His areas of interest include hematological disorders of elderly, acute leukemia, MDS, and MPNs. To his credit, he has several peer-reviewed articles in both international and national journals. He regularly conducts socially oriented health education programs. He conducts yearly CMEs for the fellow colleagues. So I request Dr. Prashant Bhatt to inaugurate our today's webinar and give some words of wisdom. Over to you, Dr. Prashant.
Dr. Prashant, we can't hear you, sir.
You are able to hear now?
Yes.
Yes, sir.
Yeah. Okay. There was some issue. So, good morning, everybody. So, I think at the outset, I thank MB Agarwal, sir, for giving me this opportunity to inaugurate today's wonderful webinar. Wonderful topic on newer antimicrobials. I'm eagerly waiting to listen to this talk, actually. I know there are a lot of postgraduate students who are listening to my talk here. At the outset, I want to assure all of you, hematology is the most beautiful subject in medicine that we have. I don't have any doubts in telling that. It's one of the most challenging, one of the most delightful subjects. You have spectrum of diseases that you are dealing with, from benign to malignant diseases. And as you all know, blood flows in to each and every organ of the body. So disease anywhere in any part of the body, blood gets affected. Same way, the diseases of the blood gets manifested in various organs of the body. So as a hematologist, you are kind of known to each and every medical professional across the board. Whether it is ENT surgeon, orthopedician, obstetrician, all of them will know you, and you also will know most of your clinical colleagues across the board in your town or in your institute where you are practicing. And you will have a wonderful liaison. In Sanskrit, they tell something called Ajata Shatru, the man with no enemies. A hematologist will be like that. Everybody would like to have an interaction with the hematologist, because there are so many intriguing problems, and the exposure to hematology in post-graduation setting is very minimal. So a lot of the people don't understand the intricacies of hematology. So it's wonderful to be a hematologist. In last 10 years of my practice, I have never regretted why I became a hematologist. Even once it never came across to me that, did I make a wrong choice? I have relished my career as a hematologist in the last 10 years. My association with my patho department or all my clinical colleagues, it has been wonderful. You kind of become one of the team person in each and every difficult case in your hospital, and you involve in most of the patient care. It is wonderful. So I congratulate all those students who have taken hematology as your career, have chosen hematology as your career, and I encourage all those postgraduate students who are yet to decide what you want to become. I encourage you people to become a hematologist, because We are only a handful of hematologists in the entire country. This country needs another at least 2,000 to 3,000 hematologists as such. You know, most of the hematologists we are there, we are all settled in most of the metropolitan cities, the second tier cities, third tier cities. We don't have hematologists, so the scope is huge. The respect you get from the society, from your colleagues is big. So never hesitate to join hematology. And with that words, I formally inaugurate today's session. And I thank Dr. Satish for introducing me, and over to you, Satish.
Thank you so much, Prashant, for sparing your time and giving your valuable advice to inspire youngsters and colleagues. And I like the word Ajatashatru. I think that's an apt word for hematology. Thank you so much, Prashant. It's time for the main webinar of the day. Now I will introduce our guest speaker, Dr. Ayesha Sunawala. It's a privilege to introduce her. I think most of us know her. She has already been to MHG and has presented a couple of webinars in the past. I have myself attended 2 webinars, interesting hematology ID cases, and optimum vaccination for hematological patients. She is a very, very good speaker, very crisp, and we learned a lot during the last webinars, and we are looking forward for this webinar. So Dr. Ayesha J. Sunawala is a consultant infectious disease specialist at PD Hinduja Hospital and Medical Research Center, Mahim, Mumbai. She's also a visiting consultant, Breach Candy Hospital and Jaslok Hospital, Mumbai. She's a teacher and head fellowship in ID. She's a member of the scientific committee for Indian COVID-19 guidelines group. Dr. Ayesha is also a co-author of the textbook, Casebook of HIV Medicine. She has received Women's Achievers Award from the Government of Maharashtra for the services rendered during the COVID pandemic. She's also the recipient of Economic Times Award for Inspiring Infectious Disease Specialist 2022. We're really privileged to have you, ma'am. Over to you, ma'am, for presenting the lecture on modern antibacterial drugs in neutropenic subjects.
Thank you, Dr. Satish. That was a very kind introduction. And I thank Dr. M.B. Agarwal for inviting me here once again. It's really an honor and a privilege to be invited here. So I'm sharing my screen. Can everyone see my screen?
Yes, ma'am.
Okay. So the neutropenic patient more often is really precariously positioned like this prism over here. And it just takes the slightest momentary nudge to tip them over. And so timely and prompt intervention is really important in the febrile neutropenic patient. Now, we live in a time of incredulous paradox. Most of us who work in tertiary care centers in large cities have moved on from conventional microbiology, and our microbiology looks like this today, which is our blood cultures are put into machines like this, and we get results in a matter of hours on automated machines like the Vitek here. Some of us who are fortunate even have mass spectroscopy machines like this MALDI-TOF machine over here, which has a huge database of different organisms and can even give you sensitivities. And then we moved on to PCR and molecular tests and even next genome sequencing. And with the help of everything that we have here, within a few hours of sending our cultures, we have a plethora of microorganisms, includes some unheard of microorganisms with very complex resistance patterns like these. So you have different ESBLs, you have this. And in the course of this talk, I'm going to show you how, especially in this sickest, most vulnerable group of febrile neutropenics, it's extremely important that we understand these things, because these resistance patterns go hand in hand with our cultures and with what we choose as antibiotics in today's world. Unfortunately, despite having all this at our fingertips in a few hours, we just have a handful of drugs to play with. So what is that handful of drugs? And what is the attributes of an ideal drug that we would really look for in a neutropenic patient? Of course, as empiric therapy, you want broad spectrum agents. You want agents that are rapidly bactericidal, that achieve concentrations at different sites, some difficult to retarget sites like the CNS. We want agents that have stable pharmacokinetics while our patients are so unstable and variable. Those which cause minimal collateral damage. We must remember the microbiome, which has already been so disturbed by chemotherapy in these patients. Agents that cause minimal toxicity. So agents which have a broad therapeutic index, minimal drug interactions, and drugs that are inexpensive. Let's face it, such an agent does not exist. So what do we have? And let's start with our gram-negative armamentarium. We have the beta-lactam, beta-lactamase inhibitors. And what we have with us approved is piperacillin tazobactam and cefoperazone sulbactam. We have carbapenems. We have the polymyxins, which are colistin and polymyxin B. We have tigecycline and minocycline for some organisms. We have fosfomycin. And now we have ceftazidime avibactam, which we choose to use either alone or in combination with astrinam. I'm going to restrict myself to these because these are what is available to us today, and this is what is relevant to our setting today. So let me try to explain these with the help of this very prototypical case of a 52-year-old with morbid obesity, acute myeloid leukemia. She was on dasatinib and venetoclax. She was admitted to us with febrile neutropenia and loose stools. And the oncology team had started her on piperacillin tazobactam. She was on a mold active prophylaxis, posaconazole, which was ongoing. Her blood cultures were sent. So within a few hours of the blood culture, if something actually flags positive in the back deck, they immediately do what is a BCID panel or a PCR test on it. Now, this is an expensive test. It costs anywhere between 10 to 15,000 rupees, but it gives you the organism, it identifies the gram-negative organism, and it gives you the basic resistance pattern within a period of hours. And having discussed it with the intensivists and microbiologists at our hospital, we feel that for patients like this in the ICU, time is money. So this is what you will get here. So in this patient, we had E. coli detected, and you can see here, resistance gene detected CTXM. So what do we understand by this? We have an E. coli, which is CTXM. By genotypic definition, this is an ESBL pathogen. So the beta-lactamases are classified as per the Ambler classification system, and you have various classes, but the most common are these variants of CTXM. You have other ESBLs like TEM and SHV. You also have some OXAs, and then organisms like Pseudomonas may express different genes like GES, PER, Web. I don't mean to confuse you with all these things, just to understand that the only thing that we can detect on our currently available PCR test is CTXM, which is the commonest gene worldwide for ESBL. So this is the only ESBL genetic mechanism that we can identify. And what does this correspond to when we finally get our culture report about 48 hours later? This is a phenotypic definition of an extended spectrum beta-lactamase. So it's the ability to hydrolyze penicillins, as you can see here, second and third generation cephalosporins, and astrinam, which is not shown in this report here. ESBL knocks out the penicillins, the second and third generation cephalosporins, and monobactams like astrinam. The beta-lactam, beta-lactamase inhibitors like piperacillin tazobactam, cefoperazone sulbactam, and the carbapenems, as you can see here, are usually spared. Question now is, would you continue with piperacillin tazobactam in this patient? You can see here that it's given as susceptible. So this really is part of an ongoing debate, and let's take you through it. So are ESBLs really our problem? And quite clearly they are. Even in the community, you can see India has one of the highest rates of extended spectrum beta-lactamase gram-negative organisms in the world. And this 70 to 80% is not our hospitalized patients. These are our community isolates. So the seeds of doubt were first planted by studies like this that appeared in somewhere in 2015. And this was a retrospective analysis of about 103 patients who received either piperacillin tazobactam empirically, which was then stepped up to meropenem when an ESBL isolate was identified, or half of them that received meropenem right from the start. And what did they find? They found that the patients receiving piperacillin tazobactam had a 1.9 time adjusted risk of death by day 14 as compared to meropenem. So clearly their mortality risk was greater in this study, but they also found that 99% of these patients had piperacillin tazobactam MICs which were greater than 4, so moving towards the higher side. Most of them received this dose of piperacillin tazobactam, which is not what we have as a formulation in India, and a lot of them had high inoculum infections. So what is this inoculum effect? And why is it so important in our patients? The inoculum effect is a phenomena of reduced efficacy of an antimicrobial when the organism burden is increased. And we know that in the febrile neutropenic, the organism burden is probably the highest as it is in any of the other patients, as compared to any of the other patients. Now, this inoculum effect may either be quantified by time kill curves like this, where you can see a change in the population size depending on the inoculum. You can see with higher inoculums, the log kill is much slower. So this is the inoculum effect by a time kill curve, and it can also be seen in vitro by a rise in MIC for higher inoculums. Piperacillin tazobactam MIC is known to increase when the inocula reach 10 colony-forming units per ml, and this is a plausible explanation for reduced efficacy in vivo despite in vitro efficacy. Now, it was this landmark trial in 2018 that really set the ball rolling for carbapenems in ESBL isolates and also got the debate raging on this issue. Now, this was not a retrospective trial. This was as good as they come, international, multi-center, randomized control trial of piperacillin tazobactam versus meropenem for the definitive treatment of bloodstream infections with either E. coli or Klebsiella species. And here they used ceftriaxone resistance or non-susceptibility as a surrogate marker for ESBL. They were not able to genotype all of these isolates, but they used this as the phenotypic surrogate for ESBL isolates. What do they find? All-cause 30-day mortality was much higher, 12.3% in the piptazo arm compared to just 3.7% in the meropenem arm. So piptazo did not meet the primary endpoint of non-inferiority. The trial was actually terminated prematurely, and they went on to say that these findings do not support the use of piperacillin tazobactam in this setting of bloodstream infections due to ESBL isolates. And here you can see the Kaplan-Meier graphs for the primary outcome, showing you a much higher risk of death with piperacillin tazobactam. Secondary outcomes like clinical and microbiological success, secondary infections, all very much in favor of the use of meropenem on these forest plots here. But there were ambiguities in this trial, and that sparked off the debate here. People who scrutinized the trial, experts who scrutinized the trial, felt that the treatment arms were not well matched. And you can see over here that whereas diabetics and urinary tract infections were much more common in the meropenem arm, the immunocompromised were higher in the piperacillin tazobactam arm. Most deaths at 30 days were attributed to other causes like terminal cancer, other secondary infections, comorbidities, etc. They felt it was an underpowered non-inferiority trial statistically, that by statistical analysis, you would require a much larger size to measure non-inferiority. And so they felt that terminating this trial early, when they had recruited just a fifth of the samples required, would have led to a random overestimation of the effect. So statistically, it was torn down. And ceftriaxone sensitivity being taken as a surrogate for ESBL was also questionable. And that's because they found that ESBLs, apart from CTXM, may be caused due to various other genes. And most of the isolates in this study carried CTXM and OXA. And when both these genes are present in combination, they actually are associated with much higher piperacillin tazobactam MICs. And you can see that from recent studies like this, that when you look at just the CTXM isolate on your ESBLs, the green part, you can see the MICs are much lower. But as you move on to OXA ESBLs in gray, which is CTXM plus OXA, you can see how the MICs start rising. How are these MICs calculated? So I'll take you back to that automated machine that I spoke of right in the beginning. Most of our labs use the Vitek 2. You can also have the Microscan, the Phoenix, various other automated systems, but they pretty much look like this. So they have these little sort of plastic trays with pre-prepared wells and antibiotics of different concentration. And into these wells, you inoculate your bacterial culture. And the wells are put into the machine, and the machine spews out the organism, the identification, the sensitivities, gives you the MIC, and also tells you what are the MIC breakpoints. So you can compare the MIC with its breakpoint and decide whether the drug is sensitive or not. So this is how it's done in a modern microbiology laboratory today. However, is this a perfect system? Is it flawless? No. And so post hoc data from this study, when they looked at it and they checked it by more robust broth microdilution systems, they found that almost 18% of the samples were actually resistant to piperacillin tazobactam, which were checked early on automated systems like Vitek. So this was a huge error. And for these higher MICs, they felt that the piperacillin tazobactam dosing was not pharmacokinetically optimized, especially in patients like the critically ill, obese, patients with augmented renal clearance, and febrile neutropenics. And hence, based on this study and the holes that were punched into this study, especially with piperacillin MICs on automated systems, the CLSI is the United States regulatory body that actually gives us the breakpoint MICs and the susceptibilities of all the drugs for different organisms. They changed their susceptibilities for piperacillin tazobactam from 16 to 8 in early 2022. And what is this SDD that they made the earlier 16 into? That is dose-dependent susceptibility. What does that mean? It means that if your MIC for piperacillin tazobactam for that particular organism is less than 8, you can get away with 3.375 or 4.5 grams 6 to 8 hourly as a bolus infusion. But if it falls into the SDD range, you're looking at a higher dosing of only 4.5 grams 6 hourly with an extended infusion period is what they recommend for pharmacological or pharmacokinetic optimization of this drug. So coming back to the question that I raised with respect to the case, would you continue piperacillin tazobactam in this patient? She was shifted to ICU with progressive respiratory distress. She was an NIV support. She was hypotensive. She was encephalopathic. You can see these bilateral infiltrates on her chest X-ray here, and you can see her skin. So this is something that was brought to our notice, that she had these erythematous sort of lesions on the skin. They were non-tender, they were non-pruritic, but you can see there is a central sort of darkening, perhaps an earlier necrosis that's developing, almost like a targetoid skin lesion. And she had this in 1 or 2 places on her limbs initially. So she was stepped up to meropenem and teicoplanin. Her cultures were repeated, a skin biopsy was done. And let's move on to trying to answer this question. We did step up. So food for thought, BLBLIs versus carbapenems. And what we do understand from all the data that we have today is that we could consider BLBLIs. We're always looking for ways to spare our carbapenems. Our antimicrobial resistance rates are just so incredulous that we're always looking for ways to step down and be judicious and most conservative with the use of our reserve drugs. So we could get away with piperacillin tazobactam or the beta-lactamase inhibitors for patients who have, say, an uncomplicated UTI or a simple skin and soft tissue infection, no CNS involvement. They poorly penetrate the CNS. In cases where source control is likely and possible, like a catheter-related bloodstream infection or a CAUTI, where you may remove the catheter, surgical debridement of abscesses, easy to debride sites. A healthcare naive patient is more likely to respond to piperacillin tazobactam. no known colonization or infection with a carbapenem-resistant organism in the previous admissions, low piperacillin tazobactam MICs of less than or equal to 4 micrograms per ml. And if you have the possibility to understand the genotype, ESBL genotypes, we know that OXA types have inherently higher MICs. But currently, our PCR reports, our genotypic reports do not pick up OXA. So we don't have any way of knowing this. Consider a carbapenem if, on the other hand, you have a complicated or a deep-seated infection, difficult to penetrate sites like the CNS, infective endocarditis, high inoculum infections, especially febrile neutropenic unstable patients, hemodynamically unstable, where source control is difficult, critical patients, pyelonephritis, precarious catheters, precious catheters, healthcare experienced patients, and anybody who's had colonization or infection with a carbapenem-resistant organism, we're always a little more alert, especially in the few months after that, and especially in our febrile neutropenics who keep coming back and getting admitted and have a lot of healthcare exposure. So it's not wrong to start with your piperacillin tazobactam in the naive patients, but be watchful of these things as the course of the illness goes along. Carbapenems, unfortunately, are the new augmentin of critical care. What do we understand about them spectrum-wise? The gram-positive spectrum, we know that they all pretty much have the same spectrum of activity against streptococci, to a lesser extent, methicillin-sensitive Staph aureus, but they're certainly not the drugs of choice for Staph aureus. They don't work against Enterococcus except for imipenem, which has some activity only against Enterococcus faecalis. In the gram-negative spectrum, again, most of them have broad, good gram-negative coverage against most isolates, except for imipenem, which works weakly for Haemophilus, Morganella, Proteus, and Providentia. It's not as good as the others. And we must remember that ertapenem doesn't have pseudomonal activity or doesn't work for Acinetobacter. That's important for us to remember. Anaerobes wise, they all cover anaerobes extremely well. It's very important for us to remember the intrinsic resistance of each drug. So intrinsically, the carbapenems are resistant to any methicillin-resistant isolates, whether they are Staph aureus or Coagulase negative Staph, to Enterococcus, except for imipenem, as I said, some activity against Enterococcus faecalis. They're intrinsically resistant to Stenotrophomonas, Elizabeth Kingia meningoseptica, Chrysobacterium. These are tongue twister bugs which we're getting more and more familiar with because these are selected in a healthcare setup in an ICU where there is a very heavy burden of carbapenem use. And the heavy burden of carbapenem use actually selects these gram-negative organisms which are inherently resistant to the carbapenems. So once again, her blood culture came back and flagged positive. And this was a report that we got in a couple of hours. This is a Klebsiella pneumonia. And you can see here that the resistance genes detected are CTXM. So CTXM, as I pointed out earlier, is your gene for ESBL and the only ESBL gene present on these reports. She also had NDM and OXA48-like. So NDM and OXA48-like are part of the carbapenemases. What are the carbapenemases that we have that are available on this report? KPCs, which are not very common in our country, NDM, OXA48-like, WIM. We also have MCR1 on this report, of course, which was not present in this patient, but MCR1 indicates polymyxin or colistin resistance, which can also be detected on this PCR report. You have the MEK gene, which picks up MRSA. You have the VAN-A, VAN-B gene, which detects vancomycin-resistant Enterococcus faecae. So when we talk about the carbapenemases or the enzymes which confer resistance to the carbapenems, what do we see in our setting and how are they classified? So just like the ESBLs, you have a class A, which is mostly the KPCs, which are barely 5% of our isolates in India. These are the ones that are predominantly seen in the US and other parts of Europe. Then you have metallo-beta-lactamases, which is, there's a zinc moiety in these beta-lactamases, and they are the most famous of them being the New Delhi metallo-beta-lactamase or NDM. Others are WIM and IM. These comprise about 40 to 60% of our isolates. And then you have the class D OXA family. And you call this OXA 48-like because it includes OXA 181, 23, 40, various other ones. And this is also a growing majority of our isolates today are OXA. There is often an overlap of NDM and OXA, as you saw in this patient over here. So there may be multiple resistance mechanisms for a single bug in a patient, and that's something that we have to be cognizant of. And so here we have a blood culture, which is corroborating with that genotypic report, showing you a carbapenem-resistant isolate. We had the same organism growing from the urine, and this was a CCT of her abdomen, showing you these renal hypodensities bilaterally, which was suggestive of a bilateral pyelonephritis. What if you don't do the BCID panel? As I said, the BCID panel, which we run on our ICU patients as soon as something flags positive in the culture, costs somewhere between 10 and 15,000 rupees. And we understand that in cost restraints, that settings, this is not possible. What can you do once you have a report like this? How do you choose? You just have a couple of drugs at your fingertips to play around with, but is there anything that will help us decide better? You can ask for an expert CABA report. This is cheaper. This is a couple of thousand rupees. And this will tell you exactly what your resistance pattern is. Again, it only picks up the carbapenem resistance. So it's only to be asked for once you have already isolated your carbapenem resistance mechanism. You may ask for this, and it'll detect the enzyme that is responsible for the carbapenemase production. We want to know what's happening with colistin, and that should never be given on a report like this, because colistin MIC can never be judged on an automated system. It must be done by a robust broth microdilution techniques, and I'll come a little bit more to this in detail. If I can continue with my case, we have this AML, febrile neutropenic septic shock in encephalopathy. Excuse the spelling error over there. Bilateral chest infiltrates, which could have been HCAP, ARDS, PCP, dasatinib-induced lung injury. We were wondering about this. The skin lesions with necrotic centers, you can see how it's evolving over here. We thought of ecthyma gangrenosum and mold infections. As I recall, she was on mold active prophylaxis already, and we were checking her levels. Her beta-D-glucan was negative. Blood and urine cultures growing Klebsiella pneumonia, and the resistance genes showing NDM and OXA 48-like. So where do we go from here? What are our drug options? On this report, if you have only OXA 48-like, you can use either one of the polymyxins or ceftazidime avibactam alone, sold as Zavicefta in our country, produced by Pfizer. If we have just KPC, we can use colistin or polymyxin, or again, Zavicefta or ceftazidime avibactam alone. All right, this drug is a BLBLI, it's a non-beta lactamase inhibitor BLBLI. It's a new generation one, but this can be used alone. However, if we have an NDM isolated or a metallo-beta lactamase, which would include the family of NDM, IM, and VIM, or we have NDM with another pathway, most commonly OXA in our setting, we can get away with colistin or polymyxin, or we may choose to use ceftazidime avibactam plus aztreonam, and I'll come to that. I'm just showing you what our options are over here. Why aztreonam? We said that as part of the ESBL definition, aztreonam also gets knocked out. Aztreonam loses its effectivity or its efficacy when there is an ESBL isolate. However, aztreonam works perfectly well and is not hydrolyzed by the metallo-beta lactamases. It's not hydrolyzed by NDM. However, more than 95% of the isolates today are not pure carbapenemase producers. They will always have ESBL resistance as well. And so aztreonam cannot work on its own. So aztreonam is given to target the NDM, whereas ceftazidime avibactam is working against the ESBL isolates and the OXA, which is also present. So in combination, these two drugs can offer some hope for these patients. And this was actually shown very nicely in an in vitro study by Avery and all called the zone of hope. So this is where the West actually meets the Indian jugaad and agrees with it. That we're so pressed against the wall when it comes to antimicrobial resistance that we're really clutching onto straws. And you can see here that they have accepted, putting ceftazidime, avibactam, and aztreonam strips one on top of the other or crossing each other to increase the zone of inhibition and improve sensitivity. And this is called the zone of hope. Does this actually work even in vivo? We'll come to that. So how do we choose between polymyxin B and polymyxin-based therapies and ceftazidime, avibactam plus minus aztreonam combination for our carbapenem-resistant gram-negative infection? There's a very good document which was published in 2019. It's the International Consensus Guideline for the optimal use of polymyxins. And it discusses susceptibility testing, MIC breakpoints, dosing, colistin versus polymyxin, monotherapy versus combination. What does it tell us? Most of our laboratories in India follow the CLSI guideline. So what was earlier considered MIC of less than 2, which was susceptible, is now moved to the intermediate range. Susceptibilities can only be checked by broth microdilution for colistin. Any lab that is checking colistin sensitivity by any other method, E-test, agar dilution, disc diffusion, sensi-titer, Vitek, are not reliable and they should not be accepted. It must be done by broth microdilution. And anything under 2 has to be reported as intermediate. What does intermediate mean? Clearly on this Venn diagram here, intermediate is by common sense somewhere between susceptible and resistant. What does that amount to clinically? It tells us the treatment success is more likely if you use the ceiling dose of this drug or a higher dose of this drug, if the dosing regimen is optimized pharmacokinetically, and if the infection is at a site where this antibiotic achieves adequate concentration. Success is more likely in those situations, as opposed to the converse. So they've suggested dosing based on PK/PD optimization, and I won't bore you with that, but just suffice to say that the PK/PD index of colistin is AUC by MIC, and if you optimize this correctly, you should reach a steady state average, which is an effective steady state average of 2. How do we reach that? We reach that with these ceiling doses, which we are all aware of, 9 million units of colistin to begin with, followed by about 9 million divided 12 hourly. And for polymyxin B, they calculated in international units per kg, but we go by sort of prototype of 15 lakhs as a loading, followed by 7.5 lakhs BD. We know that renal dose adjustment is required for colistin, not required for polymyxin B. What is that renal dose adjustment? So for a creat clearance up to about 60, you can get away with 8 to 9 million units. Anywhere between 30 to 60, you need to bring it down to about 5 to 6 million units per day. Below 30, you'd need even lower, and the lowest would be 4 million units per day. What about patients who are on renal replacement therapy? Again, we're talking only about colistin. Polymyxin B does not require any renal dose adjustment. So in patients who are on intermittent hemodialysis, it's now recommended that you use 4 million units on a non-dialysis day and 5 million units approximately on a dialysis day. So you supplement about 1.2 to 1.6 million units for a regular 3 to 4 hour dialysis session. For patients in the ICU who are on slow, low efficacy dialysis, you would give 10% of the baseline dose per hour of SLED. And similarly, in patients who are continuous renal, 6.6 million international units every 12 hours of CRRT. How would you choose between polymyxins, colistin, or polymyxin B? Colistin is a prodrug and it takes longer to achieve a steady state in the blood, so it's discouraged in critical illness. It achieves good levels in the urine, so it can be used in urinary tract infections. As I said, renal dose correction is required. And because it achieves levels in the urine, it's also more nephrotoxic. On the other hand, polymyxin B achieves rapid levels and it's preferred or encouraged in critically ill patients, does not achieve levels in the urine, so cannot be used for a urinary tract infection. It's relatively less nephrotoxic. It's not that it's not nephrotoxic, it's relatively less than colistin, but definitely more neurotoxic. So our patients have a lot of neurotoxicity in the form of dizziness and facial paresthesia, and some of them just can't tolerate standard doses of polymyxin B. Monotherapy versus combination. What goes in favor of combination therapy? We know that both these drugs achieve suboptimal plasma concentrations even with accepted dosing, especially in sites like the lung, the bone, the CNS. They have a very narrow therapeutic index, and so there are major dose-limiting adverse effects. You cannot increase the dose beyond a certain point. We know that there is clinical failure, emerging resistance on monotherapy, and they act as membrane stabilizers or membrane permeability enhancers when they are used synergistically with other drugs. So other cell wall acting drugs like carbapenems and glycopeptides, when used in combination with polymyxin, in vitro, the polymyxin actually enhances the susceptibility of those drugs. So these are all things in favor of combination. What goes against combination? There's genuinely no good evidence in support of combination. There are no RCTs on this matter, and that's because the group of critically ill patients who receive these drugs are really very diverse and heterogeneous, with very different sites of infection. The primary endpoint of mortality is difficult to attribute solely to this infection in these patients. And in most of the studies, all the carbapenem-resistant organisms have been grouped together, whether they're the Enterobacteriaceae like Klebsiella or E. coli or Acinetobacter or Pseudomonas. And we know that each of these has very different patterns of resistance, different sort of susceptibilities to these agents and stuff. So really the jury is still out there with regards to monotherapy or combination, but clearly in the sickest patients, we definitely use a combination because we just can't afford to take a chance otherwise. What is the final recommendation based on the international consensus? That for Enterobacteriaceae, Acinetobacter or Pseudomonas, which are carbapenem resistant, you use colistin or polymyxin B plus an additional agent to which the pathogen displays susceptible MICs. And that additional agent may be either one of the carbapenems, digocycline, fosfomycin, what have you. The second choice is for the Enterobacteriaceae or Pseudomonas, CR pseudo or CR entero. If there is no additional susceptible drug available, you use it in combination with a non-susceptible agent which has the lowest MIC respective to its breakpoint. And the second choice for Acinetobacter, we know that if there is no drug that is susceptible to the Acinetobacter, apart from polymyxin or colistin, it makes no sense to add a second drug. So you just give polymyxin B or colistin monotherapy. So this is the consensus recommendation. We know these challenges, I mean, they're all apparent. As I said, poor penetration into the lung, pleura, bone, CNS. Lung infection models actually show us that higher dose exposures may still be insufficient to achieve killing. And an inoculum effect has been demonstrated for monotherapy with reduced bacterial killing for VAP and for healthcare-associated pneumonias. So there are innumerable challenges with polymyxin, and we've been facing this over the past few years using this drug. It's important for us to remember that polymyxins are not a panacea for all gram-negative organisms, and there's a long list of gram-negative organisms which are intrinsically resistant to polymyxin. I'm not going to go through all of them, but you can see there's a long list here, and these are organisms that we often see in our sickest ICU patients. So moving on to ceftazidime avibactam plus or minus aztreonam. That is the other option available to us today for carbapenem-resistant isolates. Again, it's useful in deep-seated infections, even at sites in the CNS, bones, HCAP, VAP, as opposed to polymyxin B. This will achieve levels. High inoculum infections, neutropenic sepsis, it has been recommended. Clinical worsening despite 48 hours of polymyxin-based therapy. Well, that is debatable. There are two schools of thought. One that says, first try polymyxin-based therapy. If that fails, move on to ceftazidime avibactam. And the other school of thought says, these patients don't give you time. Use the best possible agent you can upfront. There's no real black and white there. Of course, if you have higher colistin MICs, you might want to err on the side of caution and try one of these drugs. Empiric therapy with ceftazidime avibactam plus aztreonam should only be done for Klebsiella pneumonia if you have a suspected CR Klebsiella pneumonia, for Pseudomonas and for E. coli, because there are other mechanisms of resistance and we are seeing mutant varieties in E. coli. You must give this combination only after susceptibility confirmation by synergy testing. And I showed you that synergy test with the ceftazidime, avibactam, and the astronam strip. So if your microbiology laboratory can give you a double disc synergy or a strip synergy for these two agents, nothing like it. Once you have confirmed that synergy is susceptible, you may go ahead with E. coli and Pseudomonas. None of these are perfect methods, but they're the best we can do in the current settings. So to sum that up, ceftazidime, avibactam alone, when the CR isolate shows OXA48-like genes or KPCs, which are very rarely seen. But if it's either OXA48-like or KPC, you can get away with ceftazidime, avibactam alone. Aztreonam must be added if the carbapenem-resistant isolate is an NDM, IM, or VIM. We must remember that this combination has no activity against Acinetobacter, should not be used for that, no activity against anaerobes, and most gram-positive organisms. So in patients with leaky guts, you should add an anaerobic cover. And clearly avoid it in patients with an HCAP if your hospital has a high rate of Acinetobacter. Avoid empiric therapy with this. So what do we know about studies on ceftazidime, avibactam, and Aztreonam? So this was probably the largest and in a sense a landmark study which made everybody more confident about this combination. And you can see that they saw several patients with bloodstream infection, of which 74 were immunosuppressed. And the 30-day mortality rate was 19.2% in the Cas-IV plus Aztreonam group versus 44% in the other active antibiotics group. What were the other active antibiotics that they used? Predominantly colistin and colistin combination-based therapy. And you can see that Cas-IV plus Aztreonam really fared much better owing to its more reliable pharmacokinetics and its better penetration into tissues. In hematology patients, unfortunately, we don't have too much data. We have data on just Cas-IV, multi-center retrospective, showing us good efficacy rates, and just restricted to case reports when it comes to Cas-IV plus Aztreonam for NDM isolates. However, I think that we in this country are really in a position to generate more robust studies on this combination because we're seeing it and we're using it with success in our practice more and more. Moving on to fosfomycin, as per the ICMR 2020 AMR surveillance, you can see that fosfomycin remains relatively sensitive to the E. coli isolates from the urine as compared to the other agents. When we looked at data from our own hospital some years ago, we looked across the board in E. coli, Klebsiella, and Enterobacter, looked at different resistance mechanisms, and we found that fosfomycin fared relatively well when compared to the other agents, almost as well as colistin for most of the samples. So fosfomycin is promising. It has a very broad spectrum of activity. As you can see here, highly susceptible agents, strep, MSSA, E. faecalis, variable susceptibility for the MR agents, for E. faecium, gram negatives, again works very well for E. coli among the Enterobacteriaceae, less well for Klebsiella, though it does extend its activity to Klebsiella, Enterobacter, and it's resistant to some of the gram negatives like Morganella, Acinetobacter, Burkholderia, Stenotrophomonas. Resistant to bacteroids, so again important to remember that when you're considering the anaerobes, but by and large a broad spectrum of activity, very well distributed into most sites of the body, including the CSF, eye, heart valves, lung, etc. Broad spectrum, bactericidal, has immunomodulator properties, good biofilm activity, and shows synergy with other antibiotics like aminoglycosides, fluoroquinolones, colistin, tigecycline. So what is the problem with fosfomycin? Very strongly emerging resistance when you use it as monotherapy, especially in high inoculum infections. So combination therapy is advisable for high inoculum infections, for Pseudomonas, for organisms in which there's variable sensitivity. And there are safety concerns in the elderly. Patients with cardiac and renal compromise, we find it very difficult to continue fosfomycin in a good dose in these patients because they develop a lot of intolerance in terms of dyselectrolytemia, fluid overload. So not very easy to manage this in ICU patients. Single dose oral fosfomycin. Fosfomycin is also available as sachets. Using them as single dose, intermittent dosing is something as ID physicians that we strongly discourage, because we understand the importance of this drug as a reserve drug in our carbapenem resistant isolates to use as part of a combination therapy. And when you use them in the community, either as step down or in a patient who has a CR isolate, when they're given these fosfomycin sachets, we often see MICs like this. So it so rapidly develops resistance. And you can see MICs in the range of over 1,000 over here. So really avoidable. Moving on to tigecycline, we know it's generally bacterostatic except for Streptococcus and Legionella, where it is cidal. Extremely broad spectrum, covers extensive gram-negative, gram-positive, and anaerobic cover, including MRSA, VRE, ESBL, and some carbapenemases. This extremely broad cover is a double-edged sword, because then there's substantial collateral damage as well when you're knocking out all the flora. So it affects the microbiome. And it's a good drug to use empirically in a patient in whom you don't know what to expect. But as soon as you have your cultures in, you should try to de-escalate and get onto a narrow spectrum agent. Excellent penetration into most tissues. As you can see here, it achieves 38 times the serum level in the gallbladder, much higher levels, 78 times the blood level in the alveolar cells, epithelial lining fluids, lungs, very good penetration. Overcomes major resistance pathways of other tetracyclines like doxy and mino. However, when it started out, very earlier on, there was a black box warning against tigecycline, where studies actually showed that there was increased risk of death with tigecycline compared to other antibiotics used to treat similar infections. And so for a while, this antibiotic went out of favor. However, thereafter, as recently as 2019, you have large-scale studies, meta-analysis showing you that with an appropriate high dose of tigecycline, there is equal efficacy to other susceptible agents. And really, perhaps this was premature, or we are now forced to overlook this because we really have run out of choices. So tigecycline is one of our workhorses in these patients. What we understand about our Indian isolates, again, the ICMR surveillance network showing us that for Klebsiella pneumonia, about 48% of the isolates will be susceptible to tigecycline. E. coli, almost 90%, and Acinetobacter, about 60%. So not perfect, not absolute, but it is helpful. Pharopenem. Pharopenem is certainly not something we use in the ICU for our critically ill patients, but I've chosen to just dwell upon this with one slide over here. And I urge you strongly to read this article. It's a very well-written article where, and it's published in a very prestigious infectious disease journal, the CID, where this author showed that just between 2010 and 2014, the pharopenem consumption rates rose 150% in India. And the consumption was higher than the total carbapenem consumption all across. So what exactly is pharopenem? It's not available in many parts of the Western world. It's a poorly studied hybrid, structurally similar to carbapenems. It's approved in India for respiratory tract, urinary tract, skin and soft tissue, and gynec infections. But there is a rampant off-label use for invasive drug-resistant gram-negative infections, especially as a step down on discharge. There are no CLSI or UCAST, which is the European body, breakpoints available for susceptibility testing of this agent. So technically, no microbiology laboratory should be able to tell you whether it's susceptible or resistant for a particular infection. We know in vitro that it has higher MICs compared to the other carbapenems. And so there is a lot of fear that the rampant overuse of this drug can lead to induction of carbapenemase. Pardon me, I'm going to come back to this case from time to time and I want to show you from this case that most of these patients, and this one who was present with us while I was making this presentation, actually take us through the entire antimicrobial armamentarium within one hospitalization, because they're really so vulnerable to all these terrible hospital-acquired infections and community infections that they come in with. So now we have this lady, confirmed ecthyma gangrenosum. We had a skin biopsy also showing the same Klebsiella isolate and no fungal elements seen on that skin biopsy. She had recurrence of fever spikes on ceftazidime, avibactam, and astronam. She had completed about 8 or 10 days. She was doing well, and then all of a sudden there was a recurrence of fever spikes. And now this is what we had on our blood culture. We had an Enterococcus faecium. Fortunately, it's not a vancomycin-resistant strain, but nevertheless, it's Enterococcus faecium. She was only on a gram-negative cover by this time. The other drugs had been stopped. So what are the criteria for gram-positive coverage? And this is something that we all practice, but I'll just go over it briefly. Fever despite broad spectrum, gram-negative cover. Somewhere between day 3 and day 5 is when a gram-positive will be thrown in. Or if the patient suddenly becomes hemodynamically unstable, reaches ICU for whatever reason. Presence of vascular access devices, prostheses, foreign bodies, significant oral or GI mucositis, skin and soft tissue infections, or previous colonization with MRSA and VRE are what are the generally accepted criteria. It's important for all of us to reevaluate at 72 hours. Most of our patients have received some kind of gram-negative cover, whether it's a cephalosporin, augmentin before they came to hospital. And that might obviate gram-negative growth on the culture. But there's no reason why the gram-positive culture shouldn't grow. So if there's no growth on it at about 72 hours, one should really strongly sort of reconsider keeping that drug on, because otherwise when we look at our ICU patients, no matter what we have isolated, teicoplanin is just going on and on. So what are our gram-positive options? We have the glycopeptides like vancomycin and teicoplanin. Most of the research is done on vancomycin because teicoplanin is not used in the United States. It's not available. We have daptomycin, which again is replacing the glycopeptides for us as our workhorse antibiotic. We have linezolid, ceftaroline, and levonarifloxacin, which is the new Indian drug that has come about. And I'll talk a little bit about each of these. The first thing we must remember about vancomycin and teicoplanin is that they are inferior options for methicillin-susceptible isolates. Yes, they are drugs of choice for MRSA, MRCons, but they are inferior for the methicillin-susceptible isolates. They have reduced bactericidal activity in neutropenic patients. They are associated with selection of resistant organisms like VRE. They have a very narrow therapeutic index. Therapeutic drug monitoring is strongly recommended for vancomycin, also for teicoplanin, but it's expensive and it's not readily available. And vancomycin now has a complex new dosing based on AUC by MIC calculation and no longer based on the trough level concentration. So this is again more complex. Let's look at vancomycin clearance in patients with neutropenia. And so they found that clearance was actually higher in neutropenics. You can see neutropenics with hematological malignancies also higher vancomycin clearance. And that actually amounted to a 33% higher dose of vancomycin required to achieve adequate exposure in patients with neutropenia. So this is, as I said, a drug with a narrow therapeutic index, difficult to even give ceiling doses. And if neutropenics with augmented renal clearance actually clear out this drug faster, then it's difficult to dose them with higher and higher doses because of the toxicity. What about daptomycin? So as I said, daptomycin has in many cases replaced the glycopeptides as the mainstay for empiric gram-positive choice. Daptomycin, unlike the glycopeptides, works equally well on MSSA and MRSA, so it's a good empiric choice. There's a convenient OD dosing. It has a relatively good safety profile. You need to monitor the CPK, see that the patient is on the lowest dose or not on statins at all because muscle toxicity is there. It achieves poor lung concentrations. We know it's inactivated by the surfactant in the lung, so it should be avoided in a primary pneumonia. But in a patient with a hematological sort of dissemination of an infection, a bloodstream infection, which is also involving the lungs, you could get away with daptomycin. MICs for Enterococcus faecium are often higher. So what does this report show us? It's sensitive to vanco and teicoplanin, but daptomycin is SDD. Does that mean I should avoid it? Well, it typically means exactly what this is saying, that for E. faecium, the MICs are higher. And so the CLSI has recommended that if the MICs are less than or equal to 4, daptomycin is effective when used in a higher dose. The usual dose recommended is about 6 to 8 mg per kg, but in a higher dose of 8 to 12 mg per kg, it would be effective even at an MIC of 4 or less. However, this is really in our patients who are the sickest with high inoculum infection, difficult to treat infections, poor source control. We have moved to using at least 10 milligrams of daptomycin, 10 mg per kg per day. So this is our routine dosing practice for daptomycin. What do we know about daptomycin in patients with neutropenia? So this was a study on 446 patients. 50% had severe neutropenia, as you can see, NCs less than 100. 60% had hematological malignancies, and the overall success rate over any range of ANC was about 77% with daptomycin. Adverse events were seen in about 1.6% of patients, and it led to some drug discontinuation along the way, but certainly not as significant as with vancomycin. The efficacy was more or less maintained across infections at all sites, especially in foreign body prosthetic infections where daptomycin has a good biofilm activity, neutropenics, endocarditis, osteomyelitis. And the efficacy was extended across most of the organisms, perhaps Enterococcus being the lowest, but still at 71, Staph aureus MRSA in the 70s. So that's what we understand about daptomycin. These are the newer drugs which have just entered the market about a year ago. And the first one is the fifth generation cephalosporin, perhaps a little over a year ago. So ceftaroline. This is a cephalosporin with a particular anti-MRSA property. It's a broad spectrum agent. You can see it covers a range of gram-positive organisms, sensitive gram-negative organisms, which are non-ESBL, and it has intrinsic resistance for Enterococcus faecium, Pseudomonas, Acinetobacter, Stenotrophomonas, and Anero. So cannot be used in any of these agents. What is important and what it's the USP of ceftaroline is that it's active against not only MRSA, but also vancomycin intermediate or vancomycin resistant Staph aureus, and also strains which are linezolid and daptomycin resistant. What about linezolid? Now we know that the advantage is the oral and IV formulation. Like the glycopeptides, linezolid is also inferior for MSSA and MS-cons. It's not as good as the the cloxacillin or the first generation cephalosporins are for MSSA. It's effective in its anti-toxin effect. It's very good for skin and soft tissue infections, patients who are extremely toxic. It works well in them. No renal, no hepatic dose correction required. But the additive myelotoxicity is something that always worries us. Neurotoxicity, lactic acid interactions, serotonin syndrome with patients on SSRIs, interactions with other drugs used in the ICU like fentanyl. And at the end of the day, it's bacteriostatic for Staph aureus and Enterococcus, cidal for only Streptococcus. So this was a study where they compared empiric escalation with vancomycin versus linezolid in patients with febrile neutropenia. And was the myelotoxicity really a problem? So this was a retrospective analysis of about 70 patients with febrile neutropenia. 50 received vancomycin, 23 linezolid, and they found a trend towards better efficacy in the linezolid arm, lesser days of hospitalization, faster defervescence, and the median duration of neutropenia was not really statistically different. Similarly, another larger study on 605 patients, well matched based on their comorbs, their type of illness, duration of neutropenia. Linezolid did not suppress recovery of platelet counts and did not have an effect on hemoglobin or WBCs. And the overall mortality rate was similar for both agents. So perhaps telling us that for short courses of antibiotic chemotherapy, you can perhaps get away with linezolid even in these patients. However, there's always that fear in the severely neutropenic that you can't have a drug with additive myelotoxicity. And I'd like to hear your views on this, actually. So moving on to ceftaroline. We covered ceftaroline, but this slide seems to have come into the middle over here. Ceftaroline, as I told you, was that 5th generation cephalosporin, which works well for MRSA. It's currently FDA approved only for skin and soft tissue infections and community acquired pneumonia. And its performance in both these groups was similar to comparators, lower risk of therapeutic failure. And you can see how the effect size in favor of ceftaroline becomes more pronounced as the sample size increases. So clearly ceftaroline is a promising agent. These are our Indian isolates showing ceftaroline sensitivity, and 171 isolates which were tested at Vellore. And you can see that about 50% were MRSA, 92% of the isolates were susceptible to ceftaroline. But important to remember that all 100% isolates were susceptible to vancomycin, daptomycin, and linezolid. So we have options. For gram-positive, we have options. This is also an attractive option. When we talk about its pharmacokinetic properties, ceftaroline is available only as an IV formulation, and it's shown to decrease the membrane binding of daptomycin against daptomycin non-susceptible MRSA. It's really helpful in situations where you have a prosthetic device. It improves the biofilm activity of daptomycin. There are in vitro studies to suggest this, and we've used it in prosthetic valve endocarditis. We've tried to use combinations of these drugs. Caution with ceftaroline that the overall incidence of neutropenia among cases receiving ceftaroline for more than 7 days was about 12%. And agranulocytosis with sort of profound neutropenia developed in almost 50% of these cases. So again, something for us to worry about when we're using it in our neutropenic patients. And now moving on to levonarifloxacin. Once again, I apologize for the linezolid slides coming in to the middle of that, but we can discuss it again if there's any confusion. Levonarifloxacin is one of the first drugs that is completely researched and produced in India by Wokhard. It's the new generation fluoroquinolone with a wide spectrum of activity, gram-positive agents, even which are quinolone resistant. So even when you have a Staph aureus which is resistant to levoflox and moxiflox, they claim that levonarifloxacin will be effective for those. It has activity against resistant strains like MRSA, again, vancomycin intermediate, vancomycin resistant strains. It's rapidly bactericidal, even at high inoculum infection in acidic pH. So in intracellular environment, in abscesses, it's thought to work very well. Has good antibiofilm activity, has excellent bioavailability, and is present in both an oral and intravenous formulation, and superior safety as compared to other fluoroquinolones. So it doesn't cause as much QTc prolongation, phototoxicity, nephrotoxicity, none of that. What is our Indian data on it? The MICs of levonarifloxacin and comparator antibiotics were determined using, again, the robust broth microdilution system at CMC Vellore, and these were their published results in 2020. You can see that they've shown the MIC of levonarifloxacin compared to the other drugs which are used for MRSA, and it had much lower MICs than, say, levofloxacin. So the potent activity, which is attributed to its distinctive mode of action, involves targeting the DNA gyrase as compared to the other fluoroquinolones which target topoisomerase. And it was found to be 16 times superior when compared to levofloxacin. So the DCGI has approved levonarifloxacin for skin and soft tissue infections, diabetic foot, even if they have a bloodstream infection involved. And this was a phase 3 multi-center trial where they compared oral and IV levonarifloxacin to oral and IV linezolid, and they found equal results. And they found that levonarifloxacin was non-inferior to linezolid for the treatment of these infections. However, We're still awaiting RCTs for critically ill and septic patients. I believe they are underway. The in vivo PK/PD targets and dosing is not really well studied for gram-negative infections, and it shows activity only against those gram-negative infections which are fluoroquinolone susceptible. It doesn't work against ESBL isolates or, of course, against carbapenemases. It should be avoided as empiric therapy where there is fluoroquinolone resistant gram-negative high burden. So our setting is a very high burden of fluoroquinolone resistant gram-negatives. So my recommendation is that it should be avoided as empiric therapy for gram-negatives for sure. And unfortunately, we have quality control ranges, but we don't have any official breakpoints from the CLSI as yet. And so there's no way to determine actual susceptibility for this agent. You can only compare the MIC to the other fluoroquinolones and say that it seems to be more effective. And that's what lab reports have shown. So it looks like a very promising agent, and we're eagerly awaiting more studies for this. I haven't had much experience with its use. Again, as I said, because there are other agents to choose from for MRSA, and we don't really consider it for gram-negatives. Before I stop, I'm just going to share a few slides with you, a couple of slides with you on an aspect of antimicrobials currently, which is of great concern to us. And we know that we're very proud of our all-Indian Jugaad technology, which is certainly very ingenious and even works out for short periods of time. But we know that this is not sustainable over a long period of time and may actually cause more fallouts and harm. So these are the FDA-approved beta-lactam, beta-lactamase inhibitors. And these two are the ones that are properly studied, FDA-approved. The ones in white are the ones that are available to us in India today. The other ones are sort of available in Western countries, in the US, and we're still awaiting them, but they don't really work on our NDM isolates, so they're not of much benefit to us. And these are our Jugaad combinations that are available in the Indian market. Ceftriaxone, tazobactam, ceftazidime, tazobactam, all these ratios of the cephalosporin to the BLI are actually extrapolated from these. There are no original sort of studies done on these combinations. And what does that mean? So when we have combinations with EDTA, what do we understand? That there's a discordance in the dose of EDTA in the in vitro disc that they give your lab to check for susceptibility and the in vivo concentration. There's no way of knowing that the nice big zone that is present in the disc is going to produce the same effect in the body, because in vivo, you cannot give so much EDTA to anybody. In terms of their ratio of, as I told you in the last slide, of BL to BLI, their unmatched half-lives, elimination times, and the rationale of beta-lactam with beta-lactamase inhibitor is completely unscientific. The pharmacodynamic target is not attainable. There are no robust clinical trials or efficacy data on these combinations. There are no approved clinical breakpoints. So no reputable lab can actually give you susceptibility for meropenem sulbactam or ceftazidime tazobactam or any of these combinations, because there are no approved clinical breakpoints. And in fact, they have the potential to amplify irrational use of antimicrobials, leading to more and more resistance selection. And once again, I'd strongly urge you to read this article. It's a very, very sort of impressive and thought-provoking article. And it actually pushed us to think more about this, put this up to our drug control body at Hinduja Hospital, and we've removed these unscientific combinations from our formulary at Hinduja. So one of the last slides for the day. Once again, it's very difficult to treat these sickest, most vulnerable patients without understanding our molecular point of care diagnostics. If you have a CT-XM on your PCR test, you can get away with a BL-BLI or a carbapenem, and I explained how you may choose one or the other or shift from one to the other. If it's a KPC, not commonly seen, it's a carbapenemase, but you can use ceftazidime avibactam alone or a polymyxin. If it's a metallo-beta-lactamase like NDM or its family, either the polymyxins or ceftazidime avibactam plus astrinam. Caution, when it's E. coli or Pseudomonas, you must check the synergy testing. OXA48-like, again, ceftazidime avibactam alone or polymyxins. MCR1 gene present indicates colistin resistance, and you're going to have to figure out another combination. MEK-A or the MREG indicates MRSA, for which the drugs available are vancomycin, teicoplanin, linezolid, daptomycin, ceftaroline. So a few choices there. And if you have VAN-A or VAN-B, that indicates it's a vancomycin resistant enterococcus, and your options are generally daptomycin or linezolid, or in combination with each other in very high inoculum infections. I'm just going to leave you with one question, which is a thought for the day, given that I've been harping on these molecular point of care diagnostics. So this patient is critically ill in the ICU on colistin, and you have Acinetobacter, which is isolated on this BCID panel. It says resistant genes detected, none. Would you de-escalate? And that is the fallacy of this BCID panel. Again, it is not perfect. No test is perfect. The limitations of the molecular assays are that they detect only few signature carbapenem resistance genes, which are the most common. Acinetobacter is not as much a problem of the West. These are tests that are made in the West. So it does not detect the most important carbapenemases for Acinetobacter like OXA23, 40, 58, which are found in these. And so you may miss it, and it may say none, and this may still turn out to be a carbapenem-resistant Acinetobacter. So in a patient who's sick, who's hemodynamically unstable, please do not escalate based on this report for Acinetobacter. It also cannot identify carbapenem resistance due to other mechanisms which are non-enzyme mechanisms like efflux of the drug or change in purine channels or things like that. It's not able to pick up. So remember those things. And finally, I leave you with the first few lines of one of my favorite books by Charles Dickens. And it really so beautifully sums up where we stand with antibacterials in the sickest patients today. And I'll paraphrase from it to say that it is the best of times and the worst of times. It is the age of wisdom and the age of foolishness. It is the epoch of belief and the epoch of incredulity. It is the season of light and the season of darkness. It is the spring of hope and the winter of despair. And unfortunately, on that note, that's where we stand with antimicrobials in our neutropenic patients today. Thank you. I'm open to questions.
Thank you, Dr. Aisha. That was awesome. It was an enlightening lecture and was an eye-opener. I'm sure for most of us, it was an eye-opener. It is very pertinent to us in our practice. And since we do not have a clone of Dr. Aisha in our hospitals, our Indian colleagues would like to ask us a few questions. I would request all our colleagues to switch on their videos and use your raise the hand sign if you have any questions. And the audience can also type it in the chat box. Yeah, Dr. Gopinathan, you can ask your question.
Good morning, ma'am. Thanks for the very informative lecture.
Thank you.
Regarding the antibacterial drugs, we do say a lot about infusion times. Because apart from the drug, we also recommend using an appropriate infusion time for all these drugs. So what are the common, for the common drugs, what are the recommended infusion times that you would suggest?
Okay, so when we talk about, I showed you for piperacillin tazobactam. So one is increasing the infusion times as the MICs increase, because we know that increasing the infusion times only helps you to better attain the PKPD target of time above MIC. So for the beta-lactams, definitely there's a lot of work on increasing infusion times. Extended infusions of about sort of 3 to 4 hours is what we would go with the carbapenems. 3 to 4 hours is what is recommended for the BLBLIs. 2 hours is what is recommended for ceftazidime, avibactam, and astronam. Again, infusion of ceftazidime, avibactam, and astronam, the best results are if they are infused simultaneously over 2 hours. Yeah, and we have looked at infusion times like that, and I could actually share what our sort of pharmacist has prepared with respect to all the drugs used in the ICU and the optimal infusion times if you are interested in that.
Definitely, ma'am. That would be a great help for our patients actually.
Sure.
Yeah. And second thing, when you're talking about daptomycin. So when daptomycin initially came into the market, there was a lot of things about its interaction with lung surfactant.
That's right.
Yeah. So what is your take on it, ma'am?
So that's what I mentioned over there, that daptomycin is inactivated by the surfactant in the lungs. So somebody who comes with a primary MRSA pneumonia, daptomycin is not the drug of choice. But somebody who has an infective endocarditis and throws, septic emboli into the lung, you can get away with daptomycin. Or someone who has a bloodstream infection and also has ARDS, because of it, you could get away with daptomycin. But for primary pneumonias, we avoid it.
Thank you.
Anything else, Dr. Gopinathan?
Yeah, that's it. Thank you.
Thank you, Dr. Gopinathan. Dr. Archit, your question, please.
Good afternoon, ma'am. Thank you for the class. I wanted to ask if you are actively doing therapeutic drug levels for the antibiotics which you are using in the ICU. And for some other infections like osteomyelitis, which are very difficult to treat. So do you go ahead with the antibiotic implanted cement, or is our IV antibiotic sufficient? Third question I want to ask is the recent Overcome trial, which was published in NEJM regarding colistin monotherapy versus colistin plus meropenem for critically sick patients. So it has been published over a period of 8 years. So do you think it is applicable to patients having severe febrile neutropenia in the background of hematological illness?
Okay. So to take your first question, I think Dr. Archit, you had sent me an email also about the uncommon organisms. And I tried to cover some of them. If you saw that list that I showed you initially of, what we're getting through these automated systems. Yeah. Basically, what we need to remember about the uncommon organisms is that although they're usually environmental isolates, which you would ignore in the immunocompetent, everything becomes important in your febrile neutropenic and your immunosuppressed patients. What we need to remember about these is their intrinsic resistant patterns. So some of them are intrinsically resistant to the carbapenems and others are intrinsically resistant to colistin or polymyxin B. So keeping that in mind, we would need to treat them, understanding that a lot of them are associated with outbreaks in our pediatric wards, in our ICUs, and a lot of them are associated with some kind of indwelling catheter, prosthetic device, whatever. So removing that goes a long way in treating these infections. So that was your email question that you had sent to me. Sorry, can you remind me about the first question that you asked me? You asked me about
therapeutic drug levels. Are you doing for any specific antibiotic?
We do therapeutic drug levels for all our antifungals, for our triazoles and things. And we do it for our tubercular medication. We are just starting off trying therapeutic drug levels for polymyxins. But no, unfortunately, apart from vancomycin and the aminoglycosides, we don't do therapeutic drug levels for the other drugs used in the ICU. But there's a lot of data on this, and that's an extremely pertinent question and something that we're trying to start off.
And ma'am, regarding osteomyelitis,
regarding osteomyelitis, sure. So, in general, osteomyelitis, not just osteomyelitis in the hematological malignancy group, is a very difficult entity to treat, especially when you have resistant organisms, because you're using difficult drugs, expensive drugs, drugs with toxicity for weeks on end, and sometimes even for months on end when you're retaining a prosthesis. So by all means, what you're saying is sort of extremely significant, that using combinations, using drug cement, bone beads, the antibiotic beads is something that we do routinely. And very importantly, especially in our bone tumors and our bone oncology, we have a very hard time with these patients because it's not easy to do megaprosthesis excision for these patients. So you have to find ways to give suppressive therapy, to give some kind of adjunctive therapy, and that can only be done with local antibiotics, and local antibiotics in the form of beads and cement and things. So we have sort of increased our local antibiotic armamentarium as well. Initially, we just started with a few agents like vancomycin and colistin and amic acid, but we have broadened that to include new agents, and we keep working on it. And the last question you asked me about was the NEJM trial. of colistin versus colistin plus meropenem. Again, I don't know how applicable that is to our setting. When we talk about the fact that our isolates are not KPCs, our isolates are predominantly NDMs and predominantly NDMs plus OXA in this part of the world. The carbapenems are for KPCs, the carbapenems usually, even if they are resistant, have lower MICs. Our MICs, if you look at your reports, are all more than or equal to 16. And in patients like this, the sickest patients with the highest inoculums, I'm not sure whether I'd be comfortable going with a carbapenem which is reported as resistant. I would try to find another drug which is susceptible or going to work in combination with polymyxin B, or move on to ceftazidime avibactam plus aztreonam combination. So difficult to completely apply this to our setting here.
Thank you, Dr. Archit. Ma'am, we'll take one audience question.
Sure.
Question from Nikhil. Excellent talk. You comprehensively covered all the antimicrobials we commonly used in our neutropenic patients. He has 2 to 3 questions, ma'am. The first question is, in
Sure.
what setting would you recommend adding TG cycline to ceftazidime avibactam and aztreonam?
Okay, so again, what are we not covering when we are giving ceftazidime avibactam and aztreonam? If you're giving it empirically, what you're not covering in a patient who's really sick and you want a broad spectrum cover, you're not covering Acinetobacter, you're not covering some of the gram-positive organisms like Enterococcus, MRSA, and you're not covering anaerobes. So if you want to broaden your cover to cover all these 3, tigecycline is an option, all right? Again, tigecycline is strongly sort of recommended, has excellent levels in the skin and soft tissue, has good antitoxin effects, achieves excellent levels intra-abdominally. So for an intra-abdominal sepsis, for a patient who's toxic with a skin and soft tissue infection, tigecycline would be an option. Another small caveat that we sometimes sort of think about is that as opposed to the other antibiotics, tigecycline has some protective effect for Clostridium difficile. So we think about tigecycline, and when you have a patient who has all these problems, has loose stools, you're worried about the C. diff, you're waiting for the report to come in, tigecycline has that little added benefit. But clearly it's not one of the main roles of tigecycline.
Right, ma'am. Second question, any data on emerging resistance to ceftazidime avibactam and aztreonam?
Yes, there is emerging data, especially in our isolates, which is why I made a distinction. I said for Klebsiella pneumonia, across the board, we are seeing susceptibility on the synergy test. For E. coli, we have this new resistant mutation, which is present in our isolates, okay? The PBP3 mutation, which it's known as, which has been reported by Dr. Balaji and team predominantly from CMC, the law, and then lots of other centers have also found it. And it's seen in sort of a large number of our, I wouldn't say a large number, a fair number of our E. coli isolates, varying numbers from different parts of the country. So E. coli as an empiric option in a really sick patient, I would be worried. I would want that synergy test before I just blindfoldly go for this combination. For Pseudomonas, again, we do see resistance. And again, that needs to be considered. This synergy test needs to be done. So definitely emerging resistance for both these isolates. Of course, for Acinetobacter, doesn't work, shouldn't be used.
And the third question from Dr. Nikhil is, what is your take on fluoroquinolone prophylaxis in neutropenic patients?
Right. So once again, if you look at our gram-negative isolates from India, we have a very heavy burden of MDR isolates, XDR isolates that are all fluoroquinolone resistant. So really makes, even in SBL gram-negatives, even in patients who have never had healthcare exposure, and if you look at most of their reports, fluoroquinolones are resistant. So it doesn't really make sense aping the Western guidelines and giving fluoroquinolones to our patients as prophylaxis, because you're only selecting different resistant pathways. Again, fluoroquinolones are an important cause of Clostridium difficile diarrhea, and we're seeing more and more of that in our ICUs. So things to think about, and certainly doesn't seem to make sense. We don't use any gram-negative prophylaxis for neutropenics. It's only in febrile neutropenics that we would start an antibiotic.
Thank you, Dr. Nikhil, for the questions. Dr. Ashwini, your question, please.
Good afternoon, ma'am. It was very informative talk.
Thank you.
So
Thank you.
I have few questions. In our center, we are doing surveillance cultures, stool and throat, before giving intensive chemotherapies and before transplant conditioning regimens. And accordingly, we are escalating the antibiotics, even if the earlier, we are stepping up the antibiotics earlier. So what is your opinion on that? Second thing is, the patients who we face many times, like patients who are turned out to be carbapenem resistant NDM OXA48 in sputum culture or urine culture. After they recover from the we are not getting any organism in the blood, but then we have given antibiotics like meropenem or colistin, and then later we find out that sputum is showing. So should we, now the patient is clinically improved, but the culture is showing that organism. So should we treat that, or we should just go clinical based on the clinical status of the patient? And I have one third question, which you had explained actually, regarding the loading dose in renal and hepatic dysfunctions. There are a few confusions, like the maintenance dose we adjust for the renal and hepatic, but the loading dose, should we give the highest possible dose or not? That is another question.
I'll start with the last question and just complete that. The loading dose is never compromised for any reason. Okay. Across the board, you can shut your eyes and give the loading dose. Even if you don't know the patient's creatinine, it's fluctuating, whatever it, don't worry about. Just give the loading dose. Then you can play with the maintenance doses based on what you find. Yeah, that's what we commonly practice across the board, and that is the guidance. Yeah. Your two other questions are really interlinked, about doing the stool CR screen, and the other one about treating cultures that come from the sputum and the urine and stuff. It's all about colonization. And we know that in these patients who have frequent healthcare exposure, invariably, it doesn't even take a couple of weeks. It just takes 1 or 2 hospital admissions for them to become colonized with carbapenem-resistant organisms. And you must have seen that in your practice. Sometimes you're shocked that the patient has just come for induction and he's colonized with carbapenem-resistant organisms, and you're wondering where it's coming from so quickly into hospitalization. So definitely CR screens is something that we have also done, and some things that we continue to do, when we're trying to make an empiric choice in patients. Again, it is helpful in the sickest patients because they don't give us time often. They just so rapidly deteriorate that you don't have time to escalate. And we've all lost patients, especially our AMLs and our relapses and things like that, to patients who just didn't give us time and died of dramatic gram-negative endotoxemia. So the stool CR cultures do give us some indication. We must remember that they remain positive for a long, long time. We must also remember that these patients have such leaky guts that they have a plethora of organisms that could be coming out into the bloodstream eventually. And that CR pathogen may not be the one that is actually causing the bloodstream infection right now. It may just be the one that has been selectively picked up, because that's what a stool CR screen does. It suppresses all the other flora and only checks whether carbapenem resistance is there or not. Yeah. So to start empirically, no one can grudge you on that if the patient is stool CR positive, very high risk and very unwell. But rapid de-escalation would be the way to go if you get something on cultures. Now, what happens about patients who are actually doing well on, say, piperacillin, tazobactam, or meropenem, and you find a CR organism on culture? Of course, if it's a blood culture or if it's a culture from a sterile site, I would give it more significance. I would pay more attention to it, especially in a patient like this, because we know how unstable they are. We know how things can dramatically change at any time. But if it's coming from the sputum, if it's coming from the urine, especially if it's catheterized urine sample, somebody who had been catheterized, catheter removed, whatever, we could observe, we could wait and watch. And often we've gotten away. And these are sites of colonization. They are, as I said, they're invariably colonized with CR isolates. We do get away with other antibiotics in patients, but certainly sterile sites, I would be more careful.
Okay, thank you, ma'am.
Thank you, Dr. Ashwini, for the question. Dr. Ayesha, one more question from the audience from
Sure.
Mr. Suresh. How do you treat central line infections with Burkholderia? What are the ways to prevent this infection?
Okay. So basically, Burkholderia, there are two types of Burkholderia. There's Burkholderia cepacia complex or Cynocepacia complex, whatever. And then you have Burkholderia pseudomallei. All right. What you are talking about, the question asked about the CRBSI is Burkholderia cepacia group. This is a hospital-acquired infection seen in the hospital setting, as opposed to Burkholderia pseudomallei, which is a community-acquired infection in diabetics, alcoholics, coastal areas, things like that. So we're not touching upon that. That doesn't really cause CRBSIs. That causes pneumonias and visceral abscesses. Cepacia, on the other hand, is ubiquitous in water supply. These are water organisms, soil organisms, and our hospital tap supplies and things like that are sort of from time to time have a heavy load of Burkholderia cepacia within them. So they do cause hospital outbreaks, they do cause line and device infections, and they particularly affect the immunocompromised patients. How do we go about treating them? I think as with any other line infection, you really need to rethink whether you can, do away with that line, because once you have done source control, most of your problem is solved over there. If you can't, we have actually used several different antibiotics, drugs of choice, our ceftazidime, the carbapenems, and we've actually even tried to lock our catheters with, things like levofloxacin if it is susceptible, or a minocycline if it's susceptible. TMP-SMX is also an excellent drug for Burkholderia and can be used. They would need to be treated for a prolonged period of time, especially if you're retaining the catheter inside. Repeated cultures to see that you're, eventually clearing the bacteremia. And how do you prevent this? Sort of stricter asepsis, stricter infection control, and look around your hospital. So we had an outbreak of Burkholderia cepacia at Hinduja Hospital when I was training. And we had about 7 patients with different malignancies, all onco patients who had line infections due to Burkholderia cepacia. And we did an extensive root cause analysis to try to understand where it was coming at from. We looked at everything. We looked at all the medications that they were using in common. We looked at all the sort of IV fluids and everything that was being given for potential contamination. We looked at our disinfectants to see if they were contaminated, where the source was. And of course, we looked at all the hospital's water supply. And what we finally found was that in the oncology wards, the taps had Burkholderia in their biofilm. And so we had to run, sort of steaming water through it for several hours and clear out the biofilm. And then we used high concentrations of chlorinated water for some time and, disinfected our entire water system. So those are things, it's basically infection control.
Right. Thank you so much, ma'am. A question from Dr. Mona Vijayaran. For which indication would you recommend using levonorofloxacin in febrile neutropenic patients?
So again, I said I have no personal experience with levonorofloxacin, not because I have anything against the drug, but because medico-legally I have other options available to me. I don't know how to justify the use of a drug for which there are no robust clinical studies and no breakpoints, no CLSI breakpoints that my laboratory can tell me with confidence that this drug is going to be susceptible to this particular agent, especially in a critical patient like a febrile neutropenic. So I can't answer it for a febrile neutropenic, but say I have a patient who has a prosthetic joint infection. All right, I need biofilm activity. For some reason, I cannot use the other MRSA agents. The patient is not tolerating them, cannot take IV for whatever reason. I find that the other quinolones are not susceptible or their MICs are higher. And my lab tells me that the MIC of levonorofloxacin is definitely much lower than the other quinolones for that infection. I might consider it. I understand that the cost is a lot, so I would counsel the patient, telling them that these are the limitations. But given that we have nothing else in this situation, I would consider it as a promising option and it might work, but I have no personal experience.
Thank you again. Question from Dr. Hitabi. Madam, do you remove central line for all CLA BSI other than cons?
Okay. No, my mentor, Dr. Rajiv Soman, was somebody who sort of encouraged us to do a lot of work with locking central lines. And that's because, again, most of our central line associated or our CRBSIs are in the hematological malignancy group, the febrile neutropenics, where line removal, line exchange is so difficult in these patients when you have extremely low platelet counts. Patients who are sort of on hemodialysis, for which some of them the lines are too precious, you can't keep removing those HD pots and catheters and things. So in those patients, especially the ones with gram-negative infections, we successfully locked a lot of catheters and were able to salvage them. We've also salvaged most of our gram-positive catheters, yeah. But having said that, there is a degree of caution that we need to exercise. If you can remove the catheter, it should be removed. In patients in whom it is imperative to retain it, in patients in whom it is precious, there's difficult access, you could get away with it only if the patient has a bug for which there are sort of options. There's no sort of exit site infection around the catheter. There's no dissemination of that infection with metastasis. For example, you don't have a complicated Staph aureus infection due to that catheter with endocarditis or osteomyelitis. That is an absolute no-no to catheter retention. Yeah, so if it's a simple, uncomplicated CRBSI with a drug which has enough sort of options to treat both gram-positive and gram-negative, we've managed to salvage several catheters like this. We've even published our work as posters in various conferences. We haven't had as much success with Candida, unfortunately, and that is known. So fungal catheters, definitely, fungal infection in catheters, definitely I wouldn't mess around with. I'd be very sort of adamant to try to get the catheter out. But other GNBs and staph, we have had success.
Ma'am, can you take up 2 more questions from audience?
Sure, sure.
Again, a question from Dr. Nikhil. In a patient with febrile neutropenia and no obvious clinical focus of infection, but with a positive culture report, when do you recommend stopping antimicrobials? Do you give antibiotic therapy for a fixed interval after defervescence and clinical improvement? How do you repeat culture guide you in discontinuing antibiotics? All interlinked.
Okay.
So, yes, ma'am.
I get what he's trying. Again, as you said, all interlinked there. Okay. So, I mean, the dictum is 14 days for a bloodstream infection. All right. That is the theoretical dictum. As often as these patients come in, we know that some of them have an episode of febrile neutropenia, which is treated with these, sort of broad spectrum antibiotics practically every time they come in for chemo. And it's quite impossible to keep them in for 14 days of IV antibiotics like this. So despite the fact that that is what is the recommendation, if my patient's counts have dramatically improved and he is no more neutropenic, there is complete sort of clinical and radiological improvement. The patient has defervesced for sort of 72 hours or more. We have stopped antibiotics or, sort of de-escalated, but more than de-escalated, stopped antibiotics at 10 days at least. Yeah. So that is to answer the first part of the question. There was something else that he asked with.
Do you repeat cultures to guide you in discontinuing?
Yeah, definitely for organisms like Staph aureus, for organisms like Candida, where you know that they have a tendency to metastasize and cause complicated infections at distant sites, we would repeat blood cultures. For Candida, it's actually recommended to repeat blood cultures every 24 hours, which again in our resource limited settings is not practical. We would repeat blood cultures in a patient who's improving every 72 hours. And once we have a negative blood culture, for Staph aureus, we do it at day 3, day 7. For Candida, we do a negative. Once we have a negative blood culture, we're a little more cautious about Candida and Staph aureus to complete that 14 days of treatment, at least if they are uncomplicated. Of course, if there is any evidence of complication, which is not part of your question, you had clearly said with no other issues, then the treatment would be much longer. But otherwise, minimum 14 days, and earlier if you find your patient has really improved, there's no site of infection and your counts are improving. Those counts improving is really something that gives us much confidence to de-escalate and stop.
The same thing holds good for urinary tract infections also, Dr. Aisha? Do you repeat a urine culture?
For urine, I would at least repeat a urine routine. If my pus cells are, down and they're negative, then I may not keep repeating urine cultures. Urine cultures I would repeat if I keep seeing pyuria.
Right. Thank you, Dr. Aisha. And a question from Dr. Shyam. Which one you prefer, colistin or polymyxin B for neutropenic sepsis? Is Zavicefta always to be combined with aztreonam, not any other carbapenem? The first question is, which one do you prefer, colistin or polymyxin for neutropenic sepsis?
Okay. So colistin or polymyxin for neutropenic sepsis, I explained over there how you choose. All right. Colistin, by and large, for the unstable, critically ill patient, theoretically should be discouraged because it's a pro-drug. It has its own pharmacokinetic challenges. It takes time to reach a steady state average in the blood. Sometimes, over 24 to 48 hours, which is too long a time when you're talking about a patient like this. Polymyxin rapidly, on the other hand, achieves the levels that you desire. And so it is recommended for these patients. The only reason where I would use colistin over polymyxin is, for example, in a patient where you definitely have a urosepsis with a febrile neutropenia, you know that colistin is going to penetrate into the urinary tract, whereas polymyxin B will not. So those are the patients in whom you definitely choose colistin over polymyxin B. Otherwise, we would go with polymyxin B for its superior pharmacokinetics.
And is Zavicefta always to be combined with aztreonam, not any other carbapenem?
So as I explained in my slides, you can get away with Zavicefta alone if your molecular test shows you that your carbapenem resistance is due to KPC or OXA48 only, and there is no metallo-beta-lactamase production. You can get away with Zavicefta alone. It would work very well. You're adding aztreonam for a particular purpose. You're adding aztreonam because aztreonam will selectively work against the metallo-beta-lactamase, the NDM, whereas Zavicefta can do its work against the other, the other aspects of resistance. So adding a carbapenem here is of no benefit because carbapenem cannot overcome NDM. Yeah, so that doesn't apply.
Right. Thank you so much, Dr. Aisha. Any Indian faculty, if there are any other questions? I don't see any raised hand sign. Okay. Thank you, Dr. Aisha.
Thank
it
you.
was really an eye-opener, as I said, very relevant to our practice. And thanks so much for taking your valuable time and joining us on a Sunday morning and patiently answering all our questions. I hand over to Mr. Prashant Agarwal for the vote of thanks.
Thank you.
Thank you, sir. And on the behalf of Adley Oncology, I would like to express our sincere gratitude to Dr. M.B. Agarwal that he has made us the part of this wonderful webinar. And I would like to thank Dr. Satish for the moderation. Moreover, I would like to thank Dr. Aisha for sharing their valuable insights with us today. This webinar has been an important platform for us to learn about modern medicine in neutropenia, and the expertise shared by the speaker has been truly informative and enlightening. We appreciate their time and effort in preparing and delivering the presentation. We would like to thank you, the participants and panelists, for their participation and engagement. Your thoughtful questions and feedback have contributed to a lively and productive discussion. We hope that knowledge gained from this webinar will be useful for all of you, and we look forward for such more and more events. Thank you once again, sir. Thank you.
Prashant. On behalf of MRG, I would like to thank Adley Oncology for supporting this academic activity. All of you have a nice Sunday. Take care. Bye-bye. Thank you, Dr. Aisha.
Thank you.
Bye-bye.